Thank you, everybody. Thank you for joining us today. We are pleased to offer our first webinar on the Reentry Demonstration Initiative. So we're going to kick things off, and I'm going to pass things off to Jason McGill. Jason, do you want to get us started?
Great. Good morning, everybody. Thank you for joining. I really appreciate it. My name is Jason McGill. I'm the Assistant Director here at the Healthcare Authority and in charge of our Medicaid Programs Division. And I'm here with a number of our colleagues from HCA and from our Department of Corrections, Lisa Flynn. I'd like to introduce Lisa, and I think we have an introduction slide here, Rochelle or Julia. If you want to just advance that slide, we'll get going. But really appreciate all of your attendance as well this morning to help us assess our next steps here with this wonderful opportunity. So we will have a chance to give you a sort of high-level view of what we're doing. We'll talk a little bit more about some detail from our Department of Corrections colleague, Lisa Flynn. I really appreciate our local jail and juvenile detention and JRA colleagues across the state as well. Some work underway. And thank you, Rick Bishop, for joining this morning as well to help with our question and answer sessions. And many of you know Rick and his great experience and important work throughout the state. But let me go to the next slide here after our agenda. Rochelle, were you going to handle this piece of it? And then I will talk a little bit more about the opportunity.
Yes, absolutely. Let me go through some quick housekeeping. Let's if we can go back to the Zoom slide, Julia. Thank you so much. We'll go through this really quick, and then we'll give Lisa and Rick just a moment if they wanted to pop on and introduce themselves, and then we'll get right into kind of explaining the program or this initiative and all the nuts and bolts that kind of go with it. So for today, Zoom, we are recording today's webinar. So at this time, we've muted all attendees, which means that you can hear us, but we can't hear you yet. There's going to be time at the end for Q&A, and we encourage you to submit your questions and comments using the chat function. And you can do this at any part of the presentation. You don't need to wait till the end. So if you've got something that's burning, even if you've got multiple questions, put them in chat. We want to hear from you. And of course, if you want to verbally share your input, please raise your hand using the raise hand function. And what we can do is we'll call on you during the Q&A. And if you'd like to see closed captioning or subtitles during today's webinar, you can click on the show captions function. Let's go to the next slide and talk about the speakers from today. So we just heard from Jason. We'll hear from him again in just a moment. We also have Michael Arness, and he is the Deputy Chief Policy Officer here at the Healthcare Authority. Lisa Flynn, we are so happy to have her with us today. She is from Department of Corrections, and she is the Health Services Administrator. Tyron Nixon, he is also in Healthcare Authority, and he is the Transformation Implementation Manager. And last but not least, we have Emma Oppenheim, and she is here at HCA, Healthcare Authority, and she is the Medicaid Transformation Project Director. I am kind of the MC moderator for today. My name is Rochelle Alonji, and I'm the Policy Communications Manager here at Healthcare Authority. Let's go ahead and pause right here. Jason, do you maybe want to bring on Lisa and Rick, and they can maybe share just a couple of moments with us, and then we can kind of get started from there.
Sure, and not to put you either on the spot, Elise, I know we have a slide you'll cover from DOC, so happy, but I'm glad to have you on camera to say hello. And Rick, of course, your valuable experience throughout the state and years of experience. And so thank you, and thank you to the Sheriff's Police Chiefs Association for joining the effort and along many years of assistance here with our journey, really trying to improve this very difficult system and opportunity we have with this waiver. So thank you, Lisa. Rick, if you want to say hello now, and look forward to your a more deeper conversation.
Thanks, Jason. Go for it, Lisa.
Rick, go
Sorry.
ahead. Go
No,
ahead.
no.
So, good morning. My name is Lisa Flynn. And of course, the second I turn my camera on, the dogs start barking. So I apologize for that. Rick, I'm going to let you go first so I can shut them up.
Good morning, everyone. I'm Rick Bishop. For those of you who don't know what WASPIC is, we're the Washington Association of Sheriffs and Police Chiefs. We're unique that we have every sheriff and every chief of police in the state in our membership, as well as several hundred associate members with a mission of leveraging partnerships throughout the state to improve public safety. We're just pleased and honored to be here and helping out with this valuable work. Thank you.
Thank you, Rick. Thank you, Lisa. Anything more, Lisa?
Yeah, just good morning. And again, my name is Lisa Flynn. I'm a health services administrator for the Department of Corrections here in Washington. And we have been working on this with the Healthcare Authority here for a few months in preparations, and just very, very excited to share with you some of the ideas we have going forward in this and subsequent webinars, and just really hope everybody gets on board and works with us across the state to provide better services and transitions for those folks coming out of our carceral settings. Thank you.
Thanks, Lisa. Thanks again, Rick. And you'll meet Tyron and Emma here, who will dive into most of the detail. But Michael and I will start off with just a general overview. So I think we can go to the next slide, and a reminder here, and I think a lot of your questions will be answered as we go over the slides. But again, you're welcome to use your Q&A and chat functions. And we really do intend to have a good portion of the time this morning to get into that sort of Q&A and to help address those questions that as we are developing and working on this together. And we really are the first and second state in the nation behind California, who's a few months ahead of us. But this work really has not ever been done before. So it is brand new work, and we really need to be thinking outside the box and as innovative as possible to really develop the systems here that we think will work. So we'll get into what we're talking about in terms of an overview of the waiver, and Michael Arness and I will help with some of those details, and Tyron and Emma will get into a little bit more detail about the sort of timeline and our very initial stage here of what we're calling our intent to participate. And so we'll get into some of that and some of the capacity funding that comes along with it, and again with some good Q&A times, in addition to office hour and web page resources that are available for you and colleagues. And Rochelle, correct me if I'm wrong, but I believe we're recording this, so that will be available for those who were not able to make it.
Yes, yes, sir. Absolutely. We are recording today, and I've shared a link in the chat for the PDF version of this presentation that we're running through. And I am also going to be sharing the page where all of these resources, including the recording, will be available. So in the next week or so, and then we can also send out the materials and things to all the folks that we put out the webinar invite to. So it's coming to you soon.
Excellent. Thanks, Rochelle. And again, thank you all for joining. And hopefully this will go into the level of detail you need for this point in time. You will need far more detail as we develop this together. But for your intent to participate and the next step, we want to make sure this is digestible and something that every carceral facility in the state can do at some point. And we've got some options in terms of timing. So we'll get into that. Next slide, please. Our Reentry Initiative, I suspect many of you on the call probably are already fairly well engaged with some of our work through our Reentry Advisory Work Group, our statutory committee, and other opportunities throughout the last few months of our work together. But let me just do a quick overview, and again, we'll get into a level of detail about the next steps. So what we're talking about is a Medicaid initiative, and what we call it in Washington is our Medicaid Transformation Project. Michael will get into a little bit more detail about what the project entails overall in terms of supportive services. It is in essence giving us the first time availability of paying for Medicaid, using Medicaid for services in a carceral setting. You may be aware that Medicaid is prohibited from otherwise paying during an incarceral event. And so this waiver gives us that ability and provides a pre-release service package up to 90 days prior to release, of which we are working with CMS to define that now, and hope we can get a good approach of doing that without really looking at 90 days as an eligibility period, but more as a statewide average. But it needs to be within that that time frame. And that pre-release set of services, fairly broad set of services, but spans from the Support Act, which is congressional legislation, bipartisan legislation, to really address the opioid epidemic. And so if you can think about that from the perspective of the purpose of this waiver, really to focus on care management and medication for opioid use disorder. The pre-release services includes a whole host of behavioral health services, includes the full suite of pharmacy benefits, but again, the focus being care management, so people have the transition into community care they need, and medication for opioid use disorder. It also includes other medication, particularly for alcohol use disorder. So we really want to ensure and do all we can to ensure that person's successful reentry into the community and get the health care and the supportive services they need. Next slide. So as I mentioned, it will fund, for the first time, we will be able to use Medicaid services to fund pre-release services in an incarceral setting for adults and youth, for juvenile as well. And that has a special caveat to it, that we are awaiting some of our final guidelines for the juvenile services, and we intend to use our initial intent to participate option for both settings, but we have some differences as we are working through the federal guidance. Certainly state prisons, as you'll hear from Lisa shortly, run by Department of Corrections. And we have been working very closely with Lisa and our DOC team on really assessing the options for DOC. So you'll hear from Lisa about what they are thinking, which might help you from your local either jail perspective or juvenile detention or JRA. Again, we've been working with JRA and Rick from a local jail perspective as well. But everybody's different and in a different position. So we're hopeful you will hear from Lisa and might be thinking about some of the same, sort of making that assessment from your point of view and your organization's point of view as well. And tribal jails. So we have some very important tribal jails throughout the state, in addition to working with our tribal population. Next slide, please. And Michael, I believe I'm turning to you for this slide in terms of a discussion a little bit more about our Medicaid transformation program, which is really what we call our waiver services. Michael, are you on?
Thank you, Jason. And as you noted, this is new and exciting work for a state's Medicaid program. We can do the Reentry Initiative because it was approved as a Section 1115 demonstration waiver under Medicaid. And we have wonderful partners at the at CMS, the Centers for Medicare and Medicaid Services, who we work with on this project. A waiver like the Medicaid Transformation Project 2.0 just allows the state to create and continue and develop projects that really hopefully can be adopted into the Washington State Medicaid program. And after we prove that we can pull this off and do it. The waiver itself is 5 years. It can potentially bring an additional $4 billion into the state Medicaid program. And it has other programs in it. We have about 12 programs in total, but the reentry program is certainly one of the most significant. And so I think what we ought to do is to go back to talking about reentry and go right on to you, Lisa Flynn, so we can talk about the Department of Corrections perspective and the prisons in the reentry program, because reentry is one of the most significant parts of MTP 2.0. On to you, Lisa, please.
Thanks, Michael. And yes, Lisa, please. And I might just make a quick note. Again, the waiver gives us that authority to waive that federal law I mentioned that prohibits Medicaid payment. So now we're waived to allow Medicaid payment. So that's the importance of the waiver. And the 1115 is simply the United States Code 1115 that allows the secretary, the federal Secretary of Health and Human Services, to make that waiver, which again, we now have. And, I might make the other point too. Some of the other services that the waiver offers can be very helpful for people in a reentry setting, such as supportive employment, supportive housing, such as other services as we are able to stand up and working on those social services as well. But Lisa, next slide, and let's get into Department of Corrections as their great example and work you're already doing to help figure out how to sequence this work. Lisa, please.
Well, thank you, Jason and Michael. So really the big piece of this is when we took a look at how the managed care organizations and this linkage, this early linkage, is really going to benefit the population, the transitioning population, especially those with high medical needs. Jason talked about the OUD disorders and those medications to support their successful transition, and all of these different pieces that are just really supported by research that need to be in place for an individual to have that successful reentry experience. The other piece of this that we look at from the Department of Corrections is, gosh, do you have the staffing to do this? Well, that's the other benefit to this when you start looking into it, is if we have the ability to engage managed care organizations at an earlier moment in that 90-day pre-release period, we get the additional help that we're looking for in coordinating community appointments, all sorts of different activities that are individualized on a case-by-case basis that also supports us in the work that we really want to be able to get accomplished, but may not be resourced for. So it's just going to be a win-win situation, even though a lot of assessment going into this, looking at all the benefits. It's just really worth your time to decide whether or not your agency or departments can participate. Next slide, please. As far as the goals themselves, as we target the intervention services that we need for each person, the care coordination and case management pieces are really going to give us the ability to look at all of our population versus only focusing on the high medical needs, which is what the Department of Corrections has really done up to this point, and expand our MOUD program that we have started around 2019, a little bit before that, and now continuing to grow it, seeing the success rate of individuals who participate as they're transitioning back out into the community. But in addition to that, if you're looking at individuals who have been receiving treatments for cancer, for Hep C, maybe HIV, all of those things are significant when we're talking about the carryover from the carceral treatment into the community and getting that continuity of care that is important with those high needs cases. And with the excuse me, with the rest of it, I think it's just about looking at the person as a whole, especially around physical and behavioral health needs, so that we can support and reduce recidivism wherever possible. Back to you, Jason.
Appreciate it, Lisa. And again, appreciate your partnership and your colleagues at Department of Corrections. And you have not only helped us from the beginning on some of this work, you and your colleagues, but will be available here for some question and answer as we're grappling with our next steps. And I think the next slide here, we're going to get into a little bit of further detail. And I believe I am turning it over now to Tyron and Emma to talk about some of the requirements and some of our initial steps. I sort of intimated earlier our intent to participate. What does that mean? What do you have to understand to sort of sign a template form that we have sent out? In fact, I think we already have a few applications, a few intent to participate forms in. So thank you for those facilities who've already committed to at least the next stage of our work here. So Tyron, am I turning to you to get into a little bit more detail?
That's correct.
Thank
Hey,
you,
thanks.
please.
Thanks, Jason. Good morning, everyone. For those of you whom I have not had the chance to meet yet, my name is Tyron Nixon, and I'm the Transformation Implementation Manager at the Washington State Healthcare Authority. And my purpose before you this morning is to talk about the facility requirements. So far, you've heard about Reentry Initiative. You've heard about the goals of the initiative and the benefits of participating in the initiative. What now I'm going to cover is what must carceral facilities do to participate. And if we can pivot over to the next slide, please. Okay, thank you. Participation in the initiative is voluntary, and facilities may choose to participate in one of 3 implementation cohorts based on their anticipated readiness. Facilities must meet the following milestones for participation. Milestone number 1, submit an intent to participate form. This form indicates the facility's intent to participate and which cohort the facility is elected to participate in. Additionally, the intent to participate form asks the facility information such as the name of your facility, your address and other contact information, and an average daily population. Does your facility currently use an electronic health records platform? And if so, what platform is being used? And does your facility currently have staff to perform healthcare related services? Once the healthcare authority receives a facility's completed intent to participate information, the steps complete milestone number 1 and initiates the release of capacity building funding to the facility. Milestone number 2, complete a capacity building application, which includes an implementation plan. For this milestone, the facility is describing its plan for supporting pre-release services. It includes a detailed budget covering the planned expenses and any other requests for capacity building funding support. When you look at milestone number 3, complete a readiness assessment. For this milestone, the facility is attesting to its current and/or planned readiness to support pre-release services. Milestone number 4, submit an interim progress report. This report is about the progress being made on the initial implementation. And milestone number 5 is submitting a final progress report. And this report is a report out on the overall implementation progress and outcomes. So what are the other facility requirements and mandatory activities? Let's turn the slide, please. Thanks. Facilities will need to ensure that a client can receive targeted pre-release services. And for this, services, as you heard earlier, begin 90 days prior to the expected release date. The goal is to provide medically necessary care as permitted by the waiver. Healthcare Authority recognizes that correctional settings, jails, pose unique challenges to delivering a full suite of pre-release services for all individuals. And we recognize that there are short stays, extended stays, and overall unpredictable release dates. And we've been working with our federal partner, CMS, and we are envisioning an average length of stay, where it's not about the individual stay, but the average of the entire population in the facility. Secondly, adopt an electronic health records system or platform that supports Medicaid billing. There's an opportunity, as you learned in the package you received, to participate in the healthcare management and coordination system, or what we're calling here HC-MAX. Our HC-MAX program is to implement the electronic health records and Medicaid billing. And as for a little context here, the state is purchasing a single enterprise solution and electronic health record system that will support our Medicaid clients as a healthcare management and coordination system. HCA will give facilities the option of implementing an electronic health record system by participating in HC-MAX, the HC-MAX program. And HC Max will provide facilities that access to electronic health record software and upgrades starting by the spring of 2025. That's what we're envisioning. Number 3, support the first 3 targeted pre-release services, and the other 4 are going to be remaining optional. So let's talk about that just a moment. The mandatory pre-release services are case management, medication for alcohol and opioid use disorder. Number 3, 30-day supply of medication and medical equipment and supplies at release. The 4 remaining, medication during the pre-release period, lab and radiology, services by community health workers with lived experience, and physical and behavioral clinical consultations, those 4 remaining services are going to be optional. Now that Healthcare Authority has a supportive role in the facilities participation, we have a role here as well. And let's take a look at the activities that HCA will support. Let's look at the next slide. HCA, we will assist with the establishment of provider network for each facility, provide case management. HCA will also support administrative activities such as client eligibility checks and Medicaid enrollment services. Additionally, provider enrollment and billing support. Also, at each facility's discretion, Healthcare Authority can reimburse existing providers and staff that support any of the above activities I just mentioned. Additionally, for support, Healthcare Authority plans to use a third-party administrator to support functions like application support to providers, provider enrollment, and billing. The TPA will ideally lead case management support and manage other pre-release services. More so, the TPA will be in place to oversee the functions for the managed care enrollees incarcerated in jails, the care management services, administrative services such as application support and provider enrollment, and claims payment, something like the clearinghouse services for fee-for-service enrollees who receive pre-release services. More so, as mentioned previously, there's also that opportunity to participate in HC Max to implement electronic health records and Medicaid billing. Let's talk about implementation cohorts. Next slide, please. Facilities get to choose when they want to participate. The initiative, as you heard earlier, starts at different times for participating facilities, depending on facility readiness. The first cohort, or the first group of carceral facilities to implement the initiative, launches and starts billing Medicaid July 1, 2025. So if your facility elects to participate in cohort 2, this second group of carceral facilities to implement the initiative, this launches and starts billing Medicaid January 1st, 2026. If your facility elects to participate in cohort 3, this third group of carceral facilities to implement the initiative launches and starts billing Medicaid July 1, 2026. Let's look at a visual of these milestones I just mentioned. Next slide, please. This visual shows top to bottom cohorts 1, 2, and 3. As I mentioned earlier, this is going to be cohort based. At the top from left to right, we have 5 milestones. 1, intent to participate, the implementation plan, readiness assessment, interim progress report, and finally progress reports. And then of course, when we have the go live with pre-release services date, you'll see that in green. Now, the submission of materials allows for funds distribution based on readiness. The dates here reflect due dates. And if you're in cohort number 1, here's the schedule. Let's take a look at this. Cohort number 1, if you're intending to participate, that notification needs to be back to Healthcare Authority by June 1st. Implementation plan is due October 1st, 2024. Readiness assessment will be due March 1st, 2025. Go live, of course, in green with pre-release services, and the start for billing Medicaid begins July 1, 2025. The interim progress report is due May 1st, 2026, and the final progress report will be due October 1st, 2026. Again, the submission of materials allows for funds distribution based on readiness. But what if you're in cohort number 2? Your timeline is up here for you as well. Let's take a look at those time frames. November 1. This is when you'll have to have the letter of intent or the intent to participate to us, and your go live year will be a year and a half later, January 1, 2026. And if you're in cohort number 3, important timeframes to look at, May 1st will be for the intent to participate, coming back to the Healthcare Authority. For a go live date for you will be July 2026. And a final note for this visual, if you can submit your intent to participate form by June 1st, but you could be ready sooner than November 1st, cohort number 2 or 3, one of the things I wanted to mention is that, we want to hear from you. Maybe you may be off a few days or a few weeks in between being ready. Let us know that some of you already have contacted us with that information. We'll be reaching out to you soon. But I wanted to let you know, if you're maybe a day or a week or 2 off of that, please, we want to hear from you. And going over to the next to this slideshow, the next voice you're going to hear is Emma, and she's going to talk to you about timelines and funding. Thank you, everyone.
Thank you, Tyron. Hi, everybody. My name is Emma Oppenheim. I'm the Medicaid Transformation Project Director. And as it says on the slide, I'm going to talk just a little bit more about timelines, but really about that funding piece. Next slide, please. All right, so we're essentially providing funding to facilities based upon the size, the population within each facility. So using that average daily population size. So we can provide up to 1 million for the smallest facilities, and then all the way up to 1.75 million in reentry planning and process funding for larger facilities. And then we also are providing an additional $1 million of funding for IT uses, and that can go to things like EHR funding, tablets, telehealth, things like that. So this is at a very high level, the maximum funding that each facility can receive, and facilities will be required to provide us with a budget as part of that capacity building application that outlines the amount of funding that they need and the uses for that funding. Next slide, please. So we'll just talk at a very high level about just one single milestone today and the funding associated with it. So when you submit the intent to participate form, that actually opens up 10% of the capacity building funding available to each facility. So if you're in that lowest tier, you would be eligible to receive $100,000. And then if you're in that highest tier, you would be eligible to receive $175,000. And again, just for filling out that form. And the goal is that we're providing planning funding so that you will be able to help us accomplish the next milestone, milestone 2, which is that implementation plan and the budget. And so just a reminder that the intent to participate for joining that first cohort is due to us on June 1 of this year. If you have any concerns about that deadline, please feel free to reach out and we're happy to talk more about it with you. And then the goal is to get funding out the door in July. Next slide, please. And so I think we just have a bunch of time right now to answer questions. Michelle, I don't know if we have anything in chat already.
Yes, thank you. Thank you so much, Emma. I wanted to circle back. We had a question from Deontay Damper at the beginning. I think it was when Jason was talking about the different kinds of carceral facilities. And there was a question about what are the differences. And so Deontay, if you're still with us, you're welcome to raise your hand and we can call on you, or if you want to put your question in. I'm hoping to get a little bit more detail from you on that. Oh, there we go. I see you raised your hand. Thank you. Julia, could you unmute?
Hello, can you hear me?
Yes. Oh, thank you so much. We appreciate you being here.
And I appreciate everybody on the call. My name's Deontay Damper. I'm the community organizer for Voices of Community Activists and Leaders Washington. And the question really wasn't the difference in carceral systems. I think that you were going over the plans and saying like we're still trying to work out our differences. So I was like, oh, well, what differences are those? And how can community be able to support the efforts? I guess that was the framing of the question.
Oh, I think what I meant is you've got some DOC structural differences, right? Longer term in carceral setting. We've got some shorter term issues from a local jail perspective. And then you've got juvenile and you've got ARA and then we've got juvenile. So every setting is a bit different in that regard. And then every local setting's a bit different. We have a question, for example, about MOUD, of which many facilities are already offering MOUD. Legislature's funding additional MOUD today. And so those facilities, I think, are in a better position to start this waiver sooner rather than later. And so I'm just many differences along those lines I was referring to. But more importantly, thank you. And I believe Tyron is already in contact with you
Yes.
and a number of people with lived experience
Yes.
to really understand and work together for that sort of common assistance. Thank you, Deontay.
Yes, and I say that, and I'm really grateful for this call because it's just the hope of making sure community members get access. So I'm really grateful for HCA and everybody else on the call to create the space. My other concern too is just of like when we're looking at the juvenile facilities, right? And their access to MOUD, right? As well as mental health access. So I'm grateful for the call. I would love to know get more context too in the areas of like the juvenile facilities as well and how they're going to be able to get access, because I'm quite sure with them being youth, it might be harder to navigate. So yeah, sorry.
Thank you. And that is our intent as well, particularly with those behavioral health services, that this is such a focus of and a very critical work. Thank you, Deontay. And
Thank you.
Rochelle, I see a number of other questions. Where would you like to lead us next?
Yes, thank you so much, Deontay, for jumping in. We appreciate the questions. Let me see. There was a couple questions that popped in as Jason, you and Deontay were talking, and I think that they are connected. Let me see if I can pop those up just really quick. I'm going to pop around here, so forgive me, everybody. Andre Morris asks, does that include mental health treatment?
Yes, it does. I think there's two segments of treatment that we can get into, but as I mentioned earlier, MOUD is critical. That is first and foremost treatment for a SUD related condition. However, our waiver is applicable for other behavioral health, including mental health, targeted evaluation, and treatment. And the breadth of that service is actually fairly broad. So yes, that is available, including pharmacy. Again, not just MOUD, but the entire pharmacy benefit is included. So a very significant benefit in that regard.
Very good, thank you. And also, I'm seeing Becky Betts had put a comment in here saying securing reasonable pricing and contracting. And Becky, am I correct in thinking that that was kind of along the lines of the conversation that we were just having with Deontay?
As Becky's getting off mute there, if you're able to, Becky, I think you're also talking about how are we going to pay for all. I mean, Medicaid will pay, Medicaid's fee schedule will apply, but it doesn't answer the questions about how you will stock MOUD drugs and how you will stock other pharmacy drugs. Those are some challenging facility questions, and the capacity funding will help. And then, of course, the ongoing funding for billing for those services should help. And that is, in essence, how we intend to do this.
Yeah, thank you. Those are all great points. I actually had a different question and I sent premature, so my comment wasn't complete on the chat. What I was referring to is forgive my nativity, I don't know how many facilities, carceral facilities already have EMRs or EHRs, but I was just wondering that, that could be a barrier for some as far as contracting and pricing. And was there ever thought that that could be provided contractually from the healthcare authority for those facilities that don't, knowing that could be a significant cost?
It is a great question, Becky, and Tyron touched on that. It's a program called HCMEX, and yes, that's in essence what HCA intends to do. Our timing may not be perfect, but we really are very closely aligned. So Tyron mentioned early spring of next year should be the beginning onboarding processes for those local entities, and even Department of Corrections intends to move with the HCA system. And so for those local entities, we can start that process. And then we are not certain yet when the actual online, when it will go online. End of next year, early 2026 is our goal. We're working out some of those final details now, but we have some contracts underway. We have the federal authority underway, so very significant work already underway to address that, Becky. So hopefully that will all align well for this effort.
Thank you, Jason.
Thank you for the question and follow-up.
All right. Thank you so much, Becky. I'm going to take a moment and I'm going to punt things over to Rick Bishop. He's got some questions regarding local jail questions. So Rick, I'm going to bring you on.
Great, thank you. There's a couple questions in the chat that WASPIC's been working on, and I just wanted to address them. And a third question related to the second one just popped in from Clark County. That's the average length of stay. As mentioned earlier, the average length of stay is difficult for local facilities. We have a large pretrial population that can get out with little or no notice. That is why HCA is using the average length of stay for the facility. If you have any questions about how to calculate an average length of stay or one that is recognized, WASPIC does have the National Institute of Corrections model for calculating average length of stay, ALOS, and I'll be happy to provide that to anyone in the state who needs it. That will stand up to just about anything or any questions. Second is MOUD services and then meds upon release. First of all, for those facilities who are not doing MOUD or MAT services right now, and there's a number of them because of their remote or they're very small facilities. WASPIC has a grant through HCA to provide telemedicine evaluations and then induction into MOUD upon entry into a jail. So if you need help with that, I will get Kurt, our MOUD project coordinator for WASPIC, email in the chat, or you can contact me and I'll put mine in there in a moment, and we can come to a jail near you and help you out. The third is for less their jail.
Quick, Rick. I hope it's not my side, but it might be your side. We may be losing you.
Yeah,
it's my side.
Oh, there we go. We can hear you. You got a little garbly
It's-
there for just a second.
I apologize. I'm actually at WASPIC today and my home system's better. But anyway, medications for 30 days and MOUD medication. WASPIC is in research right now looking at how to get those on site through a remote means, through different types of, lack of a better term, vending machines that a pharmacy can access through secure means, and medication is available. More to follow on that subject. So hopefully that helps with some of the questions that are in the chat, and I will put my and Kurt's email information in there.
Thank you very much, Rick. I'm going to pop over to a question that we've received from, I'm scrolling up here. Hang on. A question from Chris Kemp. And the question was, 90 days works well for DOC, but not as easy for county. Time served less than, oops. I really, really, really appreciate all the questions that are popping in. And as I'm finding that question again, I wanted to let everyone know we are in the process right now of developing a frequently asked questions and FAQ document that we will be sending and sharing out. So these questions that you all have, they're wonderful. We are so appreciative, and we'll be taking the questions that you have, we'll be plugging them in, and we will continue to build over time on this FAQ. So we'll make sure to be emailing all that stuff out. We will have all of the materials also posted up on our reentry from a carceral setting webpage. So keep the questions coming. We really appreciate. Okay, so back to Chris Kemp's question. 90 days works well for DOC, but not as easy for the county. Time served, less than 90 days, lots of moving parts. When will there be clarification on the 90 days? Emma, is that a question that you might want to start with?
Sure thing, happy to. So I think one point of clarification that we would like to provide is that for individuals in jail settings, for the most part, unless we expect an extended stay of more than 90 days, we would actually begin their services when they arrive. And that's because we know release dates can come at us whenever they happen. And also because most people are in jail for not longer than 90 days. So actually most services for folks in jails will begin when they arrive. I think the other answer to that question is that we understand again that release dates can happen with very little notice. And so we just want to be really clear that there is no punitive action that would be taken, or there would be no concern about an individual who did not receive the full 90 days that they were entitled to. However, we do ask that everyone works to provide services when they believe that an individual is eligible for them. So to the extent that we think a release date is in the future and then it gets pushed way up, like no facility would be held accountable or anything like that for not providing a full 90 days of services. The goal is to get to 90 days for individuals who will be in a facility for more than 90 days and to start services when we believe that somebody's going to be released quickly. I hope that answers the question.
Yeah,
I might just mention too.
Oh.
Please, Michael.
No, Jason, well, thank you. And then we can go right to you, Jason. Just mention that we are still in discussion with our partners, our federal partners at Centers for Medicare and Medicaid Services on getting that 90-day average approved as part of the program. We've made it clear to CMS that this is going to be a critical part of implementation for all the reasons that Emma and Rick and everyone who's been asking questions has been pointing out. So we'll stay in touch with everybody and let you know how those discussions go. And we'll continue to talk with our federal partners about the necessity of having a 90-day average for implementation. Jason, please.
No, you got it. That was what I was going to mention too, Michael. Thank you.
All right. Thank you so much. We have a question. Is there a list of EHR or electronic health record software programs that work for Medicaid billing? Michael, do you want to start that one off?
We're going to continue to encourage everybody to look at the HC Max and be a participant in that system. I'm not an expert on the electronic health record systems, but I do know that there are others besides the Epic system that we are focusing on for HC Max. There are other systems that have Medicaid billing. We don't have a list of them. I think, again, I would really encourage people to consider being a participant in the system that we have, because we can purchase that. We can purchase the Epic system if that's eventually the contract that we secure, which I believe we will. We'll get that a statewide system. You can be a participant in that. I think it'd be probably a more preferable way than trying to implement a system on your own if you're open to that. But no, I apologize. We don't have a list. I do know that there are EHRs besides Epic, though, that do have Medicaid billing modules.
Yes, many. Michael, this occurs to me as well. One, thank you for the question. Great question. Let's say you already have an EHR system and you're not interested in updating or changing it to the HCA system. Again, I highly encourage you, if you're wanting to get rid of your system, it's a perfect time to upgrade your system to the HCA system and help get it paid for. But let's say you've got your system and you're all ready to go. So we're thinking through those scenarios as well. And again, to my point earlier, many facilities are different. This is an opportunity where we can work one-on-one with you as we learn more and assess your needs versus another facility's needs, and understand how to use those capacity funding to supplement, say, your EHR to get a billing component that works, or to say work with the TPA, our third-party administrator, if that's when we get that up and running. So we're hoping to develop some of those conversations with you and understand your needs a little bit more specifically, individualized, and then work out solutions accordingly. Rochelle, where are we going next?
Yes, we've got so many great questions coming through. We've got Alan Nance, and he's asked, the final progress reports are due 1 year and 3 months after the go live date. Is the coverage period 5 years for this project and the services offered by the facilities? Who on our wonderful team of subject matter experts could speak to the question of reports?
Rochelle, I'd be happy to. And then I think, Emma, let me ask if you might come in afterwards, if there's anything that to round out the response. I'm going to talk about just the length of time of the waiver. We talked about this in the presentation about it being a 5-year waiver. This particular reentry program, of course, will be live for the duration of the waiver. Our goals when we have these demonstration initiatives, of course, is to demonstrate that they work and then find a next step. You know, how do we possibly weave them into approval of our Medicaid program, or can we look to have even another renewal of the waiver? So all of those sustainability questions are in front of us. First and foremost, we need to launch this program and demonstrate that the approval that we have to cover people with Medicaid dollars works, and that we can assist with the reentry of individuals back into the community. So that's the bigger overarching question there. And maybe Emma, is there anything that you might want to add to that? And then Rochelle, we might want to go back to the person who asked the question and see if we are probably not digging into the details as much as they might prefer.
Yes, thank you, Michael. And our wonderful Julia is unmuting the folks who've asked the question. So if there's clarifications or follow-up or anything like that, you attendees have a chance to speak to it. So the question is back to oh my gosh, I got to scroll up here again. To Alan Nance. Alan, does that answer your question? Do you have any follow-up for us on your report question?
Hi, thank you very much. Alan Nance from King County. Greatly appreciate the response. Primarily, the question is about the duration of the availability of the funding. So are we anticipating that the funding will be available for 5 years, even though the final progress reports are due in 2026 and 2027?
Yes, the funding is available for the 5 years, Alan, of the waivers. The funding really comes in two parts. There was the part that Jason McGill was talking about earlier, where we have the approval to pay for those 7 pre-release Medicaid services, and that's for the duration of the waiver. The capacity building funds that Emma and Tyron talked about more specifically will be available for 3 years, starting July 1, 2024, because those are available to help us plan and implement and launch the Reentry Initiative. So we have those 2 discrete time periods, Alan.
That's super helpful. Thank you.
Okay. Yep.
And I might just speculate here as well, Ellen, that again, fortunately, this was really rooted in bipartisan congressional legislation, the Support Act. And so our hope is, of course, that will demonstrate incredible value in these services, and that waiver will be renewed, as Michael intimated. That is, and has been the case in a number of other services across the nation and other settings. For other types of services that are waiver services. So that's the hope. Of course, we're, as the second state in the nation, no state as of yet, California is hoping to go online the end of this year. We don't know how this will work quite yet, but again, I think it's rooted in very strong bipartisan congressional legislation. So we're hopeful that say that waiver services will be renewed in the future. Rochelle, we're almost at time here, but any last question or two?
Yes, we've got one more question, and then we'll go to the next slide in just a little bit, and I'll give you some instructions about emails and upcoming resources and our office hours. So Jason, don't go too far. I think you may be able to answer this one. We have a question that is, the question is, to clarify, is the mental health treatment and pharmacy benefit part of the optional services or the required services for the initiative?
The required service is really MOUD and that care management. In addition, it is 30 days of supply of medication upon release, which is already a covered benefit, but you must ensure that it occurs upon release. And that is the logistical requirement. So that's the required set of benefits. The mandatory set of benefits. The secondary set of benefits are full pharmacy benefit, not just for MOUD, but the entire benefit, Hep C, everything under the Medicaid formulary today, which is a very broad-based formulary. In addition to, again, as I mentioned earlier, a broad set of evaluation and treatment codes for any behavioral health need, including mental health. So hopefully that helps. And I mentioned Hep C, really another important initiative that is very closely related to this work that we want to ensure we've got good Hep C treatment statewide.
Very good. Thank you. Let's jump to the next screen. And we'll talk about kind of some wrap up and some resources. So we've got a couple of options for virtual office hours. These are more occasional drop in, ask questions. Again, we will be continuing to build up an upcoming FAQ that we will be posting on that reentry from a carceral setting page. We also have some resources, and these are the materials that went out last Tuesday. There was an invite to participate from Dr. Sharissa Fatinos. We have an overview of the Reentry Initiative, and then we have that intent to participate form. It is a Word document form. We wanted to make it as easy as possible. But if you have questions, if you're having trouble with that form, if anything comes up, please email our team. We have an extremely long email, but we wanted to make sure we get it in there. So we are at HCA Reentry Demonstration Project at hca.wad.gov. So that's how you can reach us. So if you want to be put on the list or invites for upcoming webinars and our office hours next month, if you've got questions, if you want to follow up, let us know and email us at that email. And Addie or Julia, I'm wondering if maybe you could plug in that email into the chat just so folks have it. And we're a minute past here, but is there anything else from our presenters here that you would want to share before we close out?
I think you've covered it, Rochelle. I just want to emphasize again, these are great questions. If we didn't get to your question, we're going to incorporate a FAQ, Q&A as a part of our webpage work. And so we'll continue updating that and adding to it. There will be many questions. In addition, as soon as you get your intent to participate in, that gives us an opportunity to work with you a little bit more directly and then assess those more individualized needs. So look forward to that as well. Thank you, everybody.
Yes, thank you very much. And thank you, Julia, for putting in that email. And we are seeing some folks. We have Andre, Deontay, we've got some folks that are saying, yes, please include me. We will be downloading the chat, so we'll make sure to get you on those invite lists. Thank you, everybody. I wish we could have some more time. We will be offering some more in the future. So stay tuned, and thank you so much. We appreciate you.
Thank you, Rochelle. Thanks, everybody.
Bye.
Take care. Bye now.